Welcome everybody and thank you for joining the 7th Virtual Tumor Board of the Asian Geriatric Oncology Society. Today is the turn of Dr. Ajay Bapna, Dr. Tarajan Gupta and Bhagwan Mahavir Cancer Hospital from Jaipur to do us the honors. These tumor boards have become exceedingly useful because geriatric patients are not easy to treat. And there are several characteristics and scorings and evaluations that are not commonly used either by oncologists, and when geriatricians use it, they may not know the finer points of oncology. So this is a wonderful platform for having two streams together. One is the oncologist and the other is the geriatrician. And we have a wonderful set of experts here today to help us with the discussions about the two cases that Dr. Tarajan Gupta and his team are going to be presenting. So may I hand over to Dr. Tarajan Gupta with this introduction to take the proceeding further. Over to you.
Thank you, sir, for conducting such a nice tumor board. As Dr. Bapna sir also told that two streams are together here, and with the inspiration of Dr. Ajay Bapna, we have settled our geriatric oncology department on 1st October 2021. Since that, we are seeing we have done many theses and studies in geriatric oncology, and currently we are having our two residents. One of them is also doing a study in geriatric oncology. So today we are having two cases. One is the prostate cancer and second one is the lung cancer. So I think we should start from the first case. I think Srushti, first case is yours. So you can start with the prostate cancer. And she just analyzed all the parameters with her limitations and her efforts. So please start.
Okay. Good evening, everyone. Am I audible?
Yes, ma'am.
Yes, you are audible.
Okay. So I'll be presenting a case of 75-year-old gentleman with who is a case of prostatic adenocarcinoma. In a patient biodata, the patient is 75-year-old gentleman who is a former smoker and who has quit smoking since last 8 years and a social.
Sorry to interrupt you, ma'am. Ma'am, your slides are not visible, ma'am.
Just a second. Can you just help me with this?
Sure, ma'am. Ma'am, if you can open your Zoom screen, ma'am.
Sorry?
Ma'am, if you can come to your Zoom screen. Ma'am,
Yeah.
at the center bottom, there's a button, share screen. If you can click on that.
Yeah.
Then you can click on screen and then share.
Okay.
Ma'am, now if you can open your presentation.
Yeah. It's done?
Yes, ma'am. If you can put it into
Now
presentation.
make it in slideshow. Make it in slideshow.
But we can see the slide.
Perfect, ma'am. Thank you.
Okay. So he's a 75-year-old gentleman patient, and he's a former smoker who has quit smoking since last 8 years and social alcohol use. In a medical comorbidities, patient is hypertensive, known case of benign prostatic hyperplasia and also coronary artery disease, and the patient is on current medication and taking Cardes 2.5 mg, rosuvastatin 10 mg OD, ecosprin 75 mg once a day, Metexel 25 mg and Silodol D 8 plus 0.5 mg and Neuroton 75 mg with no any family history of malignancy reported. So the chief complaint, the patient had complained of right hip pain for the past 3 months duration. His PSA was elevated 13.4 nanogram per ml. The PET CT scan finding, it showed a bladder wall thickening, metastatic abdominopelvic lymph nodes, prostate, seminal vesicle, bladder base lesion, and sclerotic pelvic bone lesion. So he underwent a cystoscopy plus TURBT. It was performed on 8 of 7, 2024. And the histopathological examination confirmed to be a benign prostatic hyperplasia. Further, he underwent a CT urogram and it showed a post-TURP prostate status with loss of fat planes, enlarged seminal vesicles, bilateral lymphadenopathy, and a bladder wall thickening. So further pathology and workup results, it came out to be as the cystoscopy plus TURBT, it was performed on 22nd of December 2025. The bladder biopsy was negative for malignancy and a prostate biopsy was positive for an invasive acinar adenocarcinoma, which was confirmed with no LVI and no PNI. The lab parameters, it showed hemoglobin of 14.1 gram per deciliter, PSA level of 13.4, create clearance of 58 ml per minute, and a cardiac function of 55 to 60%. So in the geriatric assessment, first the general profile, the patient is a retired army officer and having an excellent social support network. Anthropometric data, the height was 166 centimeter, weight was 69.6 kg, and the BMI is 25 kilogram per meter square. For the frailty assessment, we use the clinical frailty scale and it came out to be 2, and the geriatric G8 screening score was 15. So the overall status, it was a well-preserved functional status with a minimal frailty indicators. In a comprehensive domain assessment, the nutrition, the BMI was 25 kilogram per meter square. Mini nutritional assessment score came to be 14, showed a normal nutrition. In a physical function, independent activities of daily living score was 4, no fall history, and time up and go test was 17 seconds. In a cognitive status, mini mental status examination was performed and the cognition found to be 27 score out of 30, and in a geriatric depression score, it is 2 with no any depression. The patient is on polypharmacy medication, taking 6 daily medication. In the sensory examination, the vision is intact and there is a sensory neuronal hearing loss for the last 4 years. So for the chemotherapy toxicity assessment risk score, that is a CARG risk score, the risk factors that were present was age more than 72 years. Monochemotherapy was planned in a full dose regimen. Genitourinary is a primary tumor with a hearing loss present. And there is no history of falls, no anemia, and these were the predicted toxicity rates as per a CARG score. That if we give a polychemotherapy and in a full dose, there is a high chance of developing 77% grade 3 to 5 chemotherapy related toxicity and 50% in monochemotherapy reduced dose, whereas 54% with polychemotherapy reduced or a monochemotherapy full dose. Thank you.
A very good presentation and a detailed analysis. I really like this presentation.
Thank you, sir.
So you are not.
Over to you,
Tara,
Bharathan.
unmute yourself, Tara.
Okay. Okay. Now I'm audible now. So I think this is a 75-year-old gentleman with metastatic prostate cancer, but excellent functional status. So if I ask my geriatrician colleagues like Dr. Anand, that from a geriatrician perspective, is this patient elderly with cancer or simply a cancer patient who happens to be elderly? If we see this functional status and all the things. Dr. Anand is there. I think he's a geriatrician, if I am correct.
Yes, he is. Anand, you are muted. Now you are
Yes,
unmuted.
sir. Sir, the assessment was correct, and he being a retired army officer, and except for polypharmacy, he's
Polypharmacy, sensory neural hearing loss, and a little bit GDS is 2, and at the same time that TAG score is 17.
yes, sir. So with that score, at least even if you are planning for surgical, I think he'll have a better outcome with this much scoring. And there's no frailty. The positive point is there's no frailty, and I think nutritional status is also good. So I think he should come out. Their assessment was good, and I think there was nothing left for what matters most would have been discussed in the better way.
So if the clinical frailty scale is 2 and cognition is preserved, then is there any red flag we find in this CGA that would make us the cautious about the standard oncological treatment and from the geriatrician point of view?
No, sir. Absolutely, I don't think when cognition is so good, and frailty scale
And
is
what
man.
about the tug that shows sometimes the muscle weakness, because the normal tug value is, I think, 12 seconds and it is going up to the 17 second.
Yes, sir. That variation is again depends upon the what was the issue with him. So tug twice, it should not differ so much. Once 10 and once 17, that should not have happened. So we have to keep in mind whether frailty is now being affected, or sarcopenia, is he developing sarcopenia, or is he having overall reduced activity of daily living.
So, Dr. Dharshitha, we will say this is a fit with monitor. We will label this patient as a fit with monitoring, or just only a vulnerable patient.
So the most important factor here, as Dr. Anand Ambali has mentioned, is I would look at the gait speed, sir, the tug being slightly prolonged. So that would again the cumulative deficits that have developed over time and have not clinically managed for us to detect in the form of any frailty tool assessment.
Somebody has a lot of background noise coming from somebody. Requesting you to mute, please.
So can I go ahead, sir?
Yeah, please go ahead.
So so what I mean to tell, the standard assessments in the form of frailty detection, the tool which we have used is a clinical frailty score. If it has just picked up it as the patient being non-frail or a robust patient, but the tug being slightly on the, gait speed being slightly prolonged, it needs a slightly careful monitoring. I mean, we do not, at the point, we do not have enough data to say if he's having vulnerabilities based on our assessment. But given that gait speed, he might be under closer supervision if he's going to develop any more deficits in future, which requires a careful monitoring. I think that is what I would assume based on the data presented, sir.
So
If the
it's
tug
perfect.
score is, if the
Yes, sir.
tug
Yes, sir.
score is changing from 10 to 17 in a short span, I think that is unusual from geriatric only point of view. And what is the reason for the change should be definitely evaluated. Is it a reversible oncology condition, or is it actually deterioration in the geriatric?
Yeah, that's one thing. I mean, if it's possible, if it was read-in again and it's consistently the same, that is it on the lower side or the higher side? I mean, that one correction is what we need to look into, sir, as you mentioned, because that's a drastic difference between 10 and 17 gauge speed.
And one thing which is alarming here, and that was mentioned by correctly by Dr. Anand also, that the polypharmacy. So I just want to discuss one thing, that at 75 years of age in our society, although this patient is having multiple comorbidities, but usually patient comes like one is the calcium, one is the pantoprazole, one is the multivitamin, and one is the revived immunity strengthening zinc, and one is the haldi, turmeric, and curcumin, etc. Especially if the patient is oncological patient. So will we consider this as a polypharmacy if the patient is not having any comorbidity but patient is taking this? And I'm sure that if I guide the patient, then please don't take these, but still he will take, but will not disclose to me again.
Agreed, sir.
So
yes, sir. I endorse your statement. It is very much true. Now, when we talk about polypharmacy, we think about irrational polypharmacy and rational polypharmacy. So, if the comorbids demands these medicines, yes, we can go ahead with even 6 or 8 medicines. But they are using non-allopathic medicines, and we have to be very careful along with the existing medicine that interacts with other medicines, and the non-allopathic medicines, especially the turmeric and all, which we have to find the side effects with other cardiac or oncological drugs interaction that we have to keep in mind. So polypharmacy, if it is rational polypharmacy, okay, but if it is irrational polypharmacy, then we need to give an assessment by stop or start criteria and B's criteria, which we do in our geriatric practice. So that will tell us that which medicines we can stop right now till the surgical and your oncology chemotherapy is been done for that.
Ghanshyam Dada, good evening, and saw you so after a long time. Now the next question to you, and even I want a guidance that our CARG score is saying that the monotherapy full dose and the polychemotherapy reduced dose, the chances of the grade 3, grade 5 toxicity is 54%. The thing is that prostate cancer, if we are planning a chemotherapy, usually treated with a single only monochemotherapy like the docetaxel, if we are planning chemotherapy. Second thing is that we know that in prostate cancer, 2 weekly docetaxel is equally good as 3 weekly docetaxel. So would you like to reduce the dose in this case if the case comes to you?
So I think so. The case is presented is absolutely a fitter patient. So I think so. I am more frail than this patient actually in regards to polypharmacy. So does this patient require chemotherapy? First, that is the question. If he requires chemotherapy, irrespective of the scores he presented, and if he is a candidate for a docetaxel, so I'll prefer a 2 weekly docetaxel.
Yeah, interrupting Ghanshyam Dada. We will discuss another option after this docetaxel. I have another question for that.
Right.
So I'm pointing out that the patient that 2 weekly docetaxel versus 3 weekly docetaxel, and that 2 weekly docetaxel was designed to decrease the toxicity in the prostate cancer. And you and me know that even we are giving that to the 80-year-old patient, and patients are taking very well. So
Absolutely.
what is your take if the CARG score is saying that the 54% chances of grade 3 to grade 5 toxicity at this CARG score of 8?
So that CARG score is because of a combination chemotherapy, and because the CARG score doesn't include what type of cancer, what type of drug you are using. So combination, suppose this is a lung cancer, and if you are using a PEM carbo or a Pacli carbo or a GEM carbo, then that has a meaning. For a prostate cancer with the docetaxel, and today there are different types of docetaxels. So you have a better form, so where you can even avoid steroids also. So I'll prefer to use a 2 weekly regimen because there is a shown same efficacy, but definitely a reduced toxicity. And the same thing with it, if the patient also requires a cabazitaxel, that is has a weekly also even.
Now my next question is to Dr. Aparna. Then nowadays we have entered in the era where, and very soon I think before retirement of our elderly, we will see the era where the chemotherapy will be the day of history only, will be a historical only. And nowadays we are seeing first abiraterone, enzalutamide. We can say this is a coronary artery disease patient, but Bayer has come up with the darolutamide that is more tolerant. So still, we can say that this is if the patient is also more frail, then will you consider that darolutamide or other drugs should be withheld or should be used cautiously in these type of patients where usually we are seeing the immunotherapy and TKI era where the drugs can be tolerated well. So Dr. Aparna, please.
Yes, sir, absolutely. I totally agree with your point, sir. When the patient is above 70 years, usually the family members are very apprehensive to take chemotherapy. And even myself, I'm also afraid to give chemotherapy to patients who are 70. So we always consider whether it's absolutely essential. Is there nothing else we can give other than chemotherapy? In prostate cancer, it is a testosterone-driven cancer. So we can absolutely consider enzalutamide or even darolutamide if the patient can afford it. And my first preference for such patients is, in fact, androgen deprivation rather than docetaxel.
So Dr. Aparna, that means if the patient is having high volume metastatic disease, suppose this patient is having high volume metastatic prostate cancer, so should you refrain from docetaxel even 2 weekly, or especially if we add over that the PAC GCSF along with that, would you refrain from the docetaxel?
Correct, sir. But suppose there are liver metastasis and visceral metastasis,
high volume disease.
High volume disease. So in that case, a careful discussion with the family is absolutely required, because the scoring also is showing that there is a 50% chance that there is toxicity. and sometimes elderly patients, we may lose them for chemotherapy also. So that discussion is very discussion is required. And as Dr. Dharshitha also mentioned, that every time we have to monitor carefully all the geriatric assessment with every cycle, and we have to be cautious when giving docetaxel to such patients.
Can I interject?
So, yes, sir.
Yeah. So in since this is a case of CA prostate, our oncologist algorithm starts with the estimating the life expectancy rather than comprehensive geriatric assessment. So which one will you prefer in deciding the treatment, the estimated life expectancy or the comprehensive geriatric assessment?
Sir, actually, prostate, the life, even with stage 4, many of our patients, they go on for years together. We have many patients who are like 5 years,
No,
6 years into the illness.
that
So,
is after treatment. But
yes, with
life
treatment,
expectancy
yes.
you need to decide using the various scales before starting the treatment.
Okay, but I'm only looking
WHO
into
scales are there.
Correct. But I'm not using it, sir. I'm using only the comprehensive geriatric assessment.
Dr. Ghanashyam, what is your opinion on this point?
Yes, sir. So definitely before the chemo. So for these patients, so as you rightly said, so we'll expect the survival before planning the therapeutic armamentarium for this patient.
Mm-hmm.
I have another point of view.
Like that, we are. Yes, sir.
Dr. Parikh wants to say something.
Yes, sir.
There is something called conditional survival. My life expectancy at birth may be 58 years. But if I'm alive and have survived up to 58 years, then my life expectancy doesn't remain 58. It moves to 70 years. So if a person has survived till 75 years, his life expectancy is now 84 or 85. Because we should not take as life expectancy as static.
Yes, sir. That's why I was just coming up that question, that if we calculate the lifespan calculator at this time point, if the patient was not having cancer, I think his lifespan should go beyond 85. I think if we calculate perfectly. So if we are discussing in the geriatric pool, and how many patients do you see with the toxicity if the patient is coming up at the 75 and this type of patients are coming to you and you are planning a docetaxel or the 2 weekly or 3 weekly? I'm not talking about the cabazitaxel, that may be more toxic. So we are planning as a 2 weekly. So how many toxicity do you see?
So 2 weekly patients, if I treat 10 patients on a 2 weekly regimen, so I think the toxicity will be less than 20%. And the same patient 3 weekly regimen, so I expect 50% of these patients will have toxicities, significant toxicities. So that's the difference.
Okay, so now my next question is to my geriatrician colleague, that if we start with a chemotherapy like 2 weekly, that is the safe regimen, so which parameter of the geriatric assessment will fall first? What do you think? We are having a polypharmacy, we are having a patient of the coronary artery disease, age 75, TUG score is 17, and sensorineural hearing loss is there.
He is likely to develop delirium, sir. The first thing that will happen post chemotherapy, we're looking at these symptoms and the scorings. He may be likely to develop delirium initially, unless there is an increased dosing of fluids. And second is his frailty score may come down again. So these two things, I think we have to consider post chemotherapy in this patient.
Yeah, I would like to add another
Yes.
point, sir. So as patients keep receiving the major, indicators or the domains which get affected are the nutrition and their function status. So a lot of times I keep hearing that they were much better prior to initiation of chemotherapy, while the first cycle or the second cycle, their quality of life has gone down dramatically. This is what I hear every day while I keep visiting patients in the chemo ward. So nutrition is definitely one which goes down, and any intercurrent infection or any cardiac decompensation which comes with worsened frailty parameters and precipitating delirium. So it's going to be a downward cascade of events with each subsequent session that they receive. There are very few, who are actually reasonably tolerating it well, and also where the other domains are not affected. I've seen very few of them so far that they've been reasonably, where their appetite is good, their nutrition is good, they've gained weight. That subset of patients are really small. But in overall way, if you see, a lot of them actually, it's a downward spiral that they go. And the frailty, since it's not a static parameter, and all of these do contribute. So the frailty is the other thing, which is 2 initially, can go to vulnerable or at least mild to moderate frailty. So that's what we commonly see, sir.
Yes, exactly. We can monitor these patients correctly, and we can start with the standard treatment, or we can start with go low and go slow. Start low and go slow.
Yes, sir.
Strategy that matters in the geriatric patients very perfectly. So I think whole the tumor panel will agree, or Purvi sir will endorse me that if so we can start with if the patient is low volume disease, then there is no question of the docetaxel to add in this patient. But if the patient is having high volume disease, then as from the opinion of Dada and our experience and Bhavna sir, that we can start with the 2 weekly docetaxel with careful monitoring of the patient, especially as per the Dr. Anand, that we should monitor for the cognitive functions also. And same time as the patient is having TUG score of 17, that shows the sometimes sarcopenia, we can monitor on every cycle that how the patient's performance is deteriorating or better. So, Bhavna sir, please.
So it is very important when we talk about the suspected chemotoxicity in these patients, what kind of drug delivery system we are using. We cannot use the conventional drugs in these patients. Suppose if we want to use the Texan, then there are better formulation which will give rise to lesser toxicity. Let me give you example of albumin-bound paclitaxel, or better formulation of the docetaxel like docetaxel if we are using. These will be much better tolerated than the conventional preparation of the same drug.
Purvi, your opinion matters, and now we can close this case and we'll move towards the second case.
Excellent discussion. Yeah, I think this is great. Tarachan, just go ahead with the second case.
Okay. Thank you, and with permission of the panel, and we are moving. Vishwakant, you can start your case.
Sharing the slides. Thank you so much. So good evening, everyone. Are my slides visible?
Yes, sir.
Okay, thank you. So coming to the next case, I'm presenting a case of a 68-year-old male who had a lung mass and brain metastasis. So coming to the demographics of the patient, was a 68-year-old male, farmer by occupation. He was an active smoker. He had no pre-existing comorbidities, not on any regular medications, and presented to us with the complaints of chest pain, dyspnea, persistent hiccups, and headache. His initial imaging showed a lung mass of approximately 4.4 centimeter in the right lower lobe of right lung with mediastinal lymphadenopathy, and MRI brain suggested a left parietal lesion measuring 2.2 into 1.2 centimeter. His biopsy was done, which showed it to be an adenocarcinoma case. With his routine laboratory showed that he had a hemoglobin of 12.5, creatinine was 0.83. His metabolic panel turned out to be normal. Cardiac assessment was also normal, with an 2D echo showing ejection fraction of 60% with normal LV cardiac function. All his infectious screening also turned out to be negative. So coming to the geriatric assessment of this patient, the patient had a very active lifestyle with a strong social support system. His height was 158 centimeter with a weight of 46.5 kg, and the BMI turned out to be 18.6. A clinical frailty scale was 1. And the first basic screening, which was G8 screening, the score turned out to be 11.5. So patient had a clinical impression on us that he had an excellent functional status despite his slightly lower BMI. Now coming to the most important domains of the geriatric evaluation, the first one being the nutritional status. The patient's BMI was 18.6 and a mini nutritional assessment score of 10. He had instrumental activities of daily living score of 4, no false history, but a TUG score was 19 seconds. He had a excellent cognition with MMSE score of 29. He has a geriatric depression scale score of 2. No previously, as he was not taking any previously on any medication, so there were no polypharmacy issues with them. And he's had a history of cataract surgery and a sensorineural hearing loss from approximately last 3 years. So as per for all the patients, we do a CARG scoring and his CARG score turned out to be 6. So the predicted grade 3 to 5 toxicity as per the CARG score were polychemotherapy if we give a full dose. He had a toxicity risk of 50% of grade 3 to 5 toxicity, while with the monochemotherapy in the reduced dose, the the toxicity risk was 25%. While again with the polychemotherapy reduced dose and monochemotherapy full dose, the toxicity risk was 32%. So in short, he was a 68-year-old male patient with lung cancer with brain mets, excellent cognition, CARG score of 6, needing some nutritional support from our end. Now over to Dr. Tarachan sir for further discussion. Thank you, sir. Sir, you are not audible, sir.
So you will have to unmute him.
Okay. So, Bhavana sir, should I start or you will continue? I should start. Okay. So, with Bhavana sir permission, I am continuing this case. So, actually, this patient is younger as numerically, but underweight with the brain metastasis. So, with my geriatrician colleagues first start that biologically, is he fitter or more vulnerable than case 1?
Sir, a very pertinent question. He is more vulnerable. Two things are bothering us. One is TUG score, and at any moment he is likely to deteriorate rapidly. And second is also nutritional assessment. The score is very low. So these two factors, his cognition is good. That's a good point. But his physical activity and his nutritional status will drastically go down to sustain his overall quality of life.
18.6 is normal for the Indian perspective, but for the global perspective, it is low or underweight. And we are using the international scales, so we should consider this as a underweight or not.
Yes, sir. We do consider towards the underweight side only because we don't use much of an blood values in this MNA. So I think it should be pertinent to our study.
Before going further, I just want to express my feelings or my observation, which I saw in daily routine and daily OPD and in my daily routine, daily life. That this is typically an Indian farmer who is looking because usually cachexic or underweight that usually happens in Indian scenario. And if we so that's why the weight may be there, because these people are too hardworking and usually they and their diet is also very nominal, very simple. Like sometimes onion and rookie roti and etc. Like this type, and they just start working immediately after they are taking lunch, and they don't take time the rest time. And usually they are carrying they don't use porter or anyone, and they carry their weight with them themselves. So this is I think this is quite common that the patients looking cachexic or you can say sarcopenic. And another thing, we are going for the TUG 19. If we ask these people to run, then these people will run faster than us. That usually happens. But in the normal life, we see these people usually walk slowly. So what is the take of the house? That am I correct or not? That usually this is a typical scene of our farmer life or not?
So Tara, I actually agree with you. So there are patients of 70 years, similar situation. They will tell that I today morning I have 10 kilometers cycling or 20 kilometers cycling, and still he goes back cycling. So which is difficult even in the park. So you are absolutely right. So these are by scales, they don't fit because G8 is less than 12 here. So if I bank on G8 to a less than 12, so it will be difficult for me to give a polypharmacy. Otherwise, the background of the profession of the patient, the normal, the nutrition that he takes, so he will be a more fitter patient in reality if you see, if you don't score them in any situation.
So, what is your take, Dr. Dharshitha?
So I definitely do agree with you, sir. I mean, we often see though patients who are falling slightly lower on our standardized scales, but their outcomes are reasonably fairer than our fitter patients. So we've seen in real life scenarios that people coming from rural background who have been predominantly we think that the nutrition is compromised, but they are able to their ability to take up any surgical stress, anesthesia, and all are remarkably good. So probably I think maybe it's time to relook at having our own standardized scales for Indian population. That's one thing I would like to add over here. And the other things is it's not just one component that could determine the treatment plan. I mean, a very thorough physical examination and also screening for sarcopenia. All of these and any other systemic parameters that are affecting inflammatory parameters is what we need to look at in a comprehensive way and then decide, especially like albumin, pre-albumin. Those things also can guide us if there are any definitive nutritional deficits, sir. I would say just the BMI, I don't think we can just go by BMI in such subset of patients. The overall nutrition, looking at our biochemical parameters can aid us slightly.
Yeah, I agree with your nutrition parameter assessment and everything. One question is that I suppose because that will be that will be there that if I go with the protein level, maybe their protein level may be low, albumin level may be low. But if the drug that is having low protein binding, like the cyclophosphamide, if I have to use, then will it matter or not?
Yes, that definitely matters. As such, the drug
Because another end is the cisplatin or paclitaxel; those are highly protein-bound drug. I can and another side is the cyclophosphamide that is low protein, having low protein binding. So
Yes.
will it decide if I am using cyclophosphamide? Then will it decide my treatment or not? Will it affect my treatment or not?
Yes, that will definitely. The sarcopenia and malnutrition, they very commonly not accepted as contributors for the adverse drug events. They've got a major role to play because how strongly is there correlation between the albumin levels and the drug binding capacity? So, and that cannot be underscored at all, sir.
So one thing, if I want to start treatment, should I wait for the nutritional to correct the nutritionally, or should I start the treatment for this patient?
So, I mean, two schools of thought here. If you're going for an elective, it's always better, like we rehabilitate and then decide, especially the major important factor here would be correcting the nutrition. That comes as the first step. But if, in fact, there is not much time, I think it can go on simultaneously. Because here, oncologists are often concerned about the more you delay, the earlier the better. So in that way, if it can start simultaneously while we equally address the nutrition components and start the treatment, yes, but it needs a little more caution.
Dada, one thing is there that the patient reports have come to me now that I have sent all the NGS PDL1 and all the things. So patient's PDL1 is 85% now. So what is your take that if this CARG score is 9, if it is showing 6 now, if it is CARG score 9 and the grade 3-5 toxicity with the chemotherapy chances are around 74%. So
now it looks like it is a driver mutation negative and it is a high PDL1. So definitely,
yes.
So I don't have a target. So I don't require chemotherapy. because this patient has a high PDL1. So rather I will start the patient on a brain RT, and post RT I will put the patient on a single agent immunotherapy, Keytruda.
So this is the standard treatment, sir. Pembrolizumab single agent is the standard treatment in a patient of PDL1 85% in a
So this patient
metastatic
will
lung
receive
cancer.
the standard treatment, because
Yep.
so we know that the chemotherapy versus immunotherapy as a single agent is definitely, it doesn't depend on so much of the even the protein binding also, and also on the because these are drugs probably in a poor performance status also probably will be able to deliver if it is a single agent not associated with chemotherapy.
So, Dr. Anand, we know that how the immunotherapy usually functions. Immunotherapy comes to the tumor point, and it comes between the tumor and our affected T cells, and release the T cells to work effectively. So, how this is the immunotherapy works, and I have come across one article that in elderly patients that the immunosenescence is also there. So do you think that the immunotherapy may cause the hypersensitivity in these patients or not? If we
Yes,
use the
sir.
immunotherapy in these frail patients, what is your take, Dr. Anand?
Yes, sir. The chances of causing immunosenescence in the patients, all elderly patients, and in us also, immunosenescence and inflammation is happening. That's why we are surviving. So immunosenescence, as you brought, it is very right, sir. And using the therapy will definitely activates the other cells and creates more harm than helping the patient in the initial phases, especially in the frailty, in the patient's frailty.
So, Dr. Aparna, you have listened. You all both the argument from the Dada and Dr. Anand. So now, what is your take?
Sir, I totally agree with your point that as we age, the elderly patients, the immune system is aging as well. But in many of the trials, they have actually taken, like, especially lung cancer, most of the trials, patients are like 60, 70. Like majority of the patient, if we take the median age or mean age, it is like 60, 65. And it works in most of the age itself is not a determining factor. I haven't read anywhere that for age more than 70 years, immunotherapy does not work. Most of the trials, patients are above 60 years, and it actually works. Even in brain metastasis, immunotherapy works. So, in a frail patient or a elderly patient with brain metastasis, and PDL1 is so good that 85%. So, I will endorse immunotherapy. But as Dr. Dharshitha and you also pointed out that our farmers, they are having a low protein diet, and they also have poor hygiene, and they are at risk for infection. They have their domestic animals with them, so there is a high chance of infection. So considering all such things, I would endorse immunotherapy rather than chemotherapy.
So, Dr. Dharshitha, both the medical oncologists in the panel are suggesting for the immunotherapy to start with, but Dr. Anand is saying, raising the red flag that immunotherapy may harm this patient, especially the CARG score is going. Now, we are not considering CARG score 6. We are considering if the CARG score is 9 and the patient is undernutrition, underweight, and MNS score is down, TAG score is down. So, what do you suggest?
So this needs a there are two parameters here. It needs very detailed counseling to the patient and the family members. That's what happened. Certain cases where I remember there was a very advanced hepatocellular carcinoma. Son is a doctor from US. So the oncologist has advised for the best supportive care. But then they insisted that, at least we try immunotherapy. Yes, I mean, as expected, he was a pretty frail man. I would say his BMI would come up to around 17 at that point when I saw him more than half a year ago. But then, as expected, he did reasonably good with immunotherapy. I mean, we were so carefully monitoring that would he develop any other systemic side effects from immunotherapy. But no, he actually did reasonably well. But only other thing, we do not know who's going to respond in which way, but it needs a very cautious approach. And cost is one thing which I would definitely consider, given our patient being a farmer. So that is what actually, refrains a lot of people from reaching out to immunotherapy. Like today, I had a patient with multiple myeloma who was asked to see, but they were, not accepting immunotherapy because they can't afford it. So that's one important factor which would determine the further plan of care, sir. So these two, I mean, the first one which I've mentioned is what probably, it depends from case to case basis. But as expected, that how we anticipate the adverse events to come up, it might not always be the same scenario. There were always some surprise cases with immunotherapy for us.
Yeah. So, Dr. Aparna, one more thing came this into picture when I saw the send the NGS. I did not reveal the NGS. I did reveal only the PDL1 that the NGS was ALK positive.
Then we have to go for ALK TKI, sir. I mean, when
Which
there is
TKI?
both ALK and
Which TKI? Which TKI?
whatever they can afford, sir. If they are
No,
like
no,
very
affordability is
poor,
not the issue. We are discussing the science here only.
yeah. Maybe alectinib, if they can.
Why not lorlatinib?
Lorlatinib, I'm not very fond of it, sir. But if the patient wants, it's okay. But I think the first choice, as per my what I have used in other patients, it is alectinib.
So, Ghanashyam Dada, please, will you tell us that what is alectinib versus lorlatinib?
So for a high risk ALK are actually a presentation with the brain mets which are symptomatic. If it is if it is a B3 type and if it is a P53. So if these three factors are there, then you have two choices. One is lorlatinib and one is brigatinib. But now if this patient has a short-term memory loss, or there is a G2 depression, so where cognitive functions abnormality is likely with the lorlatinib, if associated sugars and dyslipidemia is there, then I will prefer to give a brigatinib rather than a lorlatinib. Or if I am giving a lorlatinib, then probably at a reduced dose I'll consider in terms of a survival and also the toxicity that is going to happen in next 15 days in terms of the CNS toxicities mainly.
I think Bapna sir wants to throw some light.
No, I think I agree with Ghanashyam. Whatever he has said, we have to be very cautious in choosing the ALK inhibitor in these patients so that we can manage the toxicity and we shouldn't harm the patient at any cost.
So yes, because the lorlatinib causes the neurocognitive dysfunction also, and elderly people are usually vulnerable for the cognitive declination. So we should be careful while choosing the ALK inhibitors. And yes, that match was try with the immunotherapy or not immunotherapy at that time. So again, the one question from to my geriatrician colleague, that what supportive intervention are non-negotiable in this patient? Any geriatrician colleague can take this question?
Yeah. So if you've decided for immunotherapy, sir, I think a periodic reassessment with, most importantly, nutrition is what I would look at, and then the functional status, how is it deteriorating, and the cognitive function, and then how quickly is it going down, or are there any untoward, much more than we anticipated, any untoward side effects that crop up in between. It also goes along with simultaneously the quality of life and other ADLs and IADLs that are periodically checked into. And these are the at least important parameters that we look into, sir.
Thank you, Dr. Dharshitha. And I think we are midway that we should go because the geriatric oncology, or you can say that geriatric in oncology, is a new concept before that concept, we were treating the patient. The one target was always the elderly. So these discussions will happen till we reach a consensus or like a NCCN type guidelines where the geriatric oncology patients will be treated according to the geriatric scales along with the disease parameters, because both are needed at the same time. Yes, I agree that the patient is under nutrition and we should go for the nutrition to correct the nutrition. But the same time things is there that patient is having a lung cancer with a brain metastasis. If we leave the patient untreated, definitely he is going to have a dyspnea and the cough and chest pain that may deteriorate, and patient's PS will become 3 or 4 with the time, because my assumption is that the nutrition correction takes at least 1 month to correct it, and in the 1 month time patient will be I don't know in which condition. So we can go with the along two paths. We can take the two paths same time, so which are merging with each other. That we can start again. That the theory is the start low and go slow theory, and we can start with the low dose chemotherapy. Meanwhile, the NGS report comes, because this was just a fry or tadka in between. I have put up that the NGS and PDL1 report because the patient did not come up to us again, but after the baseline assessment. But yes, we have to discuss, because if the patient comes up with these theories, then how will we proceed? So if the patient, my take is that we should start with the low dose chemotherapy. Along with that side, we should build up the nutrition, and we can use the physiotherapy. We can take the help of physiotherapy to help in the sarcopenia. And somewhere in a last year conference, I heard that if the patient, especially geriatric patients, are going to gym, this usually we don't see here, and we usually say that please no, gym is a thing for the younger people only. If the patients are going to gym and use it and lifting the dumbbells and weight lift and etc., that overcomes the sarcopenia, and people become more fitter with the time, and we can take the treatment. We can treat patients effectively and get the better results. So I think Dr. Purvi sir will enlighten us, because there was a tie between the immunotherapy and non-immunotherapy, between the geriatrician and the medical oncologist. And at the same time, now we are having the safer drugs with us, that if this patient comes up with the EGFR positive L, that means exon 19 deletion, and the osimertinib is among the safest drug. So where we fit that these geriatric scales in the era of the drugs like osimertinib, alacritinib, and like other palbociclib and other drugs. So, Purvi sir, please throw
Thank
some
you.
light on analysis.
Thank you very much, Tharachal. I think this was a very enlightening discussion, and you have very carefully picked up the points that have to be discussed. So my first thought is that we should not feel that immunotherapy or TKIs are without toxicity. Okay. We say patient is not fit for chemotherapy, so we are using this oral medication. That is absolutely incorrect. They have a different type of toxicity, and those toxicity need not be very trivial. Some of them can be life-threatening. So the assessment of the patient could be different in terms of toxicity, but please remember that all drugs have some form of toxicity. That is the first thing. Second thing is, let us say that this patient is ALK mutation positive and we have to choose between 3 or 4 drugs. I think the choice of the drugs would be less based on the age and more based on which toxicity we want to avoid. So in a patient with brain tumor, for instance, we are definitely concerned about neurocognitive effects, irrespective of whether the person is older or younger. And we would select the drug based on avoiding the cognitive dysfunction, even for a younger person. So I think these 2 points have to be balanced, and therefore, I think the geriatricians and the oncologists are having this dialogue so that we learn from each other and therefore take a more effective discussion for the patient. I think, Tarachal, I very much like 2 points that you made. One is that age may not be a normal for the Western as opposed to what is normal for a farmer from India. And I think that is a very, very important thing. And the other thing that you mentioned is as we move forward, what happens to the patient and how we decide the treatment discussion, that is also very important. So I think you're balancing the geriatricians and the medical oncologists come out really well in this patient discussion. I will
Yes,
stop
sir.
here and
Yes, sir.
take.
If I consider this, the average lifespan at birth for the Indians is 70 years, while it is 81 years for the Japan. And sir, one thing, with your permission, I want our students presented these cases, so we may ask them if they are having any question. So, Dr. Srushti, do you have any question? This panel is there, and all the geriatrician from the national level and the medical oncologists are there. You can ask if you have any question. Dr.
Uh,
Srushti.
yeah, sir. Sir, my question is that since we were discussing that TUG score is the parameter which is one of the indicator that the patient is on a frail side. So should we take the TUG score into consideration before deciding the chemotherapy dose? As we have discussed in the first patient, the TUG score is on a higher side because the patient has a pelvic bone disease, and in the second case, the TUG score is on the higher side because since the patient has a brain lesion. So these two reasons can be that is why the patient is taking time to get up from the chair and cover the distance.
So any geriatrician can take this question, Dr. Anand or Dr. Dharshitha.
Uh, Hi. So yes, see, the TUG score cutoffs, different disabilities or different medical comorbidities are different. So let's say like somebody has Parkinson's or somebody has hemiplegia from stroke, somebody has osteoarthritis, to the matter of fact. The cutoffs are definitely different. We're not going to use the same 13.5 seconds for everyone. Okay. So it is always an overall picture of the patient that is going to guide your treatment plan. So we're not going to decide just with the help of. It is only going to be, a marker that you need to be cautious about, but that
Okay.
is not going to decide the treatment plan.
Okay. Thank you, ma'am.
And now, Dr. Vishwakant, you can ask if you have any question. You are, please unmute yourself. Vishwakant, please unmute yourself.
Sir, I have 2 or 3 questions to ask. Sir, first question I asked was if the CAR score at baseline is high, sir. So how should we be dealing it with in the clinical practice? We should be lowering the doses, or we should be shifting to monochemotherapy, or we give the first cycle of chemotherapy or the treatment we want to offer and then wait for the toxicities to occur.
Vishwakant, we discussed this case just now that we will go parallelly. We will correct the geriatric skills with like malnutrition and the underweight at the same time with the help of dietitian and the physiotherapist also. And second time we will correct the disease. We will target the disease itself. Otherwise, the PS will deteriorate with the time. So we can't wait for the time.
As we are conducting the thesis, what I found out during that course was that once we have started the treatment, the patient's nutritional assessment, with all our best efforts, we can stabilize the patient's fall of weight. But to improve the nutritional assessment, is it possible, or what steps we should be encouraging the patient should be taking to improve his MNA?
Yes, Dr.
Suppose
Anand.
the patient
Dr.
has
Dharshitha.
if the patient has cachexia and albumin is low, we have to add megestrol acetate to improve, to halt the cachexia and also to improve the appetite and weight.
Yes, Purvi sir rightly pointed out that the intent is palliative or curative, and Vishwakant is talking about that his thesis only, and that is with the curative intent, where we are using the adjuvant either in adjuvant setting or in a radical setting, concurrent chemoradiation, and we are just assessing the score because usually what we see whenever the patient come for the concurrent chemoradiation, usually radiation starts with the time, and then the patient comes to us to start the chemotherapy. Or usually in the real world scenario, we don't see that anybody is waiting for the radiation to start after the correction of any nutrition status or the other things. So these scenarios are different because, and his thesis is head and neck cancer patients, especially where the nutrition status usually affected because of either first thing because of the disease, second thing because if it is operated, then because of the anatomical disturbance, and third thing because of the mucositis and other thing which happens because of radiation, and that increases with the concurrent chemotherapy. So these parameters affect overall intake, because if we do maximum efforts, then still the daily intake will go down with the time. After at least the 3 weeks of the concurrent chemo radiation, it has to go down. This is the dictum. We cannot change this dictum. I think any medical oncologist, geriatrician can suggest if we can interfere any point in time.
I agree with you, sir, that we cannot wait for the nutrition to be corrected and then we'll go for the, as you rightly mentioned, the causes for all the nutritional decline. So I think simultaneously or concurrently, use of radiation and along with the nutritional correction, as also Madam told about correcting the cachexia, should go simultaneously hand in hand. So
So I think, Purvish sir, should we close now the meeting?
All right. Thank you very much. I think maybe we should ask Dr. Ajay Bapna to give the concluding remarks.
So,
Ajay is there?
yeah, sir,
thank you.
I'm here. So, frankly speaking, this was my first ever meeting of geriatric oncology, and I was really very curious. So, 5 years back, we started geriatric oncology clinic in our hospital, and it was a very small step. And now I see that with the consistency and perseverance of Dr. Tarachan, it has taken a beautiful shape. And I cannot forget to remember Dr. Purvish Parikh and Dr. Vanita Narona for helping us time to time in establishing this department and taking it to the new heights. This all discussion was very new to me, very interesting for me. And at the same time, I would really like to congratulate all the people who are involved in the development of geriatric oncology in country, and also taking and spreading it to the other states and the cities. Thank you very much for inviting me for this meeting.
Thank you very much, Ajay. You said a small step, so it reminded me of Neil Armstrong. He said when he first landed on the moon, he said small step for man and a big step for mankind. So you have really taken a big step for geriatric oncology. Congratulations.
And I also gave the responsibility to the right person.
All right. And just before we close, I remind you that next time on 12th of March, the turn is of Tata Hospital, and Dr. Anand Ramaswamy will be coordinating the next virtual tumor board of AGOS. So with that, I thank everybody. Thank Ajay Bapna, Tarachan, and the two residents who made a wonderful presentation. And of course, all the panelists who really contributed to the engaging discussion. Thank you very much.
Thank you. Thank you very much, everyone.
Thank
Yeah.
you.
Thank you very much.
Good night, all.
Yeah.
Good night.